Hello, everyone. We are live and we are so excited that you've joined us for our first installment of our Critical Conversations webinar series. So, just a little bit of background. I think that a lot of you know my story about having my bone marrow transplant 13 years ago and not having access to fertility preservation. And so a large part of that is what inspired us to create the Sickle Cell Reproductive Health Education Directive, or SCRED. And so this is the first one of our webinar series. We are doing these twice a month until December, and we were not going to launch this series until March, but I don't know, the community kind of expressed a sense of urgency, particularly after the gene therapy approvals, wanting more information on fertility and fertility preservation. So this is a full circle moment for me because a lot of you hear me talk about Dr. Lydia Pecker all the time, and you've seen her out and about at conferences lately, but I don't know if everyone is aware that when I share my story and talk about the hematologist who sat me down and had a conversation about my own fertility post-transplant was Dr. Lydia Pecker, who is also one of my co-founders. So I'm going to bring her up. She's going to do a presentation, and then we will have a very special reproductive endocrinologist, Dr. Clayton Vaught, to do a presentation. And you are more than welcome to submit your questions in the chat, and they will stick around after the presentations to answer them. So I'm going to get out of the way because you didn't come to see me, you came to see them. So without further ado, here's Dr. Pecker.
Good evening. I'm trying to share my slides. And I'll just say that I'm really lucky to be here with Ms. Wolford and Dr. Clayton Vaught. And one of the reasons it's really important and lucky that we're here together, it's not lucky, it's by design that we're here together. The reason I wanted to highlight that at the outset of this talk is that when I think about how to take care of people with sickle cell disease in general, and when I think about fertility and fertility preservation, what we have been learning at Hopkins together with the loving support of our patients who graciously forgive us when we don't have answers for them, is that we have to do this together, and that hematologists and other sickle cell disease experts need to learn more about these procedures around fertility preservation, and that most reproductive endocrinology and infertility experts don't have a lot of sickle cell training. And so we have to be training our expertise and also engaging our community of patients that we care for and learn from, because your questions and insights about your own experience both help inform what questions we need to be answering in the research, but also how we can think about making sure we're taking the best clinical care of people. So with that introduction, it's a real honor to be here this evening with my collaborators and to talk a little bit about how we've been thinking about fertility and fertility preservation in the context of living with sickle cell disease. Can you tell me, Tiana, I'm unfamiliar with this platform. Can you see my slides right now?
Now we can.
Okay, great. Sorry, they disappeared for a minute. All right. So with that long overview, here are some disclosures I have, mostly that I've had some consulting work with GBT and Novo Nordisk. And also I like to say, well, while this is not my focused area of expertise, and it's certainly not the subject of our discussion tonight, I absolutely believe, and SCRED absolutely believes, that boys and men with sickle cell disease equally deserve experts who are committed to ensuring that they receive individualized, high quality, and evidence-based sexual and reproductive health care. And that, is absolutely part of the mission of ensuring access for our patients. So although that's not the focus of what we do this evening, we hold in the corner of our minds that everybody deserves this care, no matter what gametes you were born with or sexual function you have. So anyway, what are the purposes today? I'm going to talk a little bit about infertility risks for people with ovaries and sickle cell disease, and talk a little bit about fertility preservation strategies for people with sickle cell, and with a real focus on the safety concerns here, which have become a central preoccupation of mine. And then after I talk, Dr. Clayton Vaught's going to talk a little more about the nitty-gritty of fertility preservation and really deliver us her deep expertise in this. And I just can't say enough how lucky I am to have her as a collaborator. I'll just start with this image. This comes from North Carolina. It's a reproductive life plan, and SC Red is working on a reproductive life plan for the sickle cell community. But if you're a young person or the parent or caregiver for a young person with sickle cell disease, it's really great to start having some of these conversations about what you imagine for your future. Because it may inform some of your treatment decisions, how you choose to build your family, if you choose to do fertility preservation. A lot of decisions could be shaped by what you imagine for your future. I always tell my patients to fill these out with pencil, not a Sharpie marker. Your reproductive life plan is always allowed to change. So we're not saying anything is set in stone once you set it. In any case, I'll talk a little bit about a 28-year-old with SS disease who came to me for preconception counseling. She was diagnosed at birth. Her brother was cured by a matched sibling donor of transplant. Her adolescence was interrupted by acute chest pain and menstruation-associated pain, daily back pain, and avascular necrosis. She started in that context on hydroxyurea and oral contraceptive pills, and she was very adherent to hydroxyurea, did a great job of taking her medicine, and had a mean corpuscular volume greater than 115. I met her when she wanted to get pregnant after she got married. And so, this is a long list. We're not going to talk about all these things today, but I just wanted to briefly prepare our community for other reproductive events, other reproductive ideas that are coming down the pipe this year. If you don't want to be pregnant, you should consider yourself fertile until proven otherwise with this disease. There's no reason to think that you're infertile unless somebody specifically counsels you that you're at high risk for infertility at the very moment that you're being counseled. And so if you don't want to be pregnant, contraception approach is really important. It is not the focus of our talk today, but I did want to put on everybody's radar that in the next 6 months, this says spring, it's probably going to be a little later than that. The CDC is going to issue updated guidance for sickle cell disease and hormonal contraception. And so we're all kind of waiting for that guidance to come out. But if you're somebody who's thinking about what kind of contraception you should be using as a person with sickle cell disease, this guidance is going to change, and it is going to be restrictive of estrogen-containing contraception. So again, just so everybody can pay attention to that in the coming months. So what do you do if you're planning to get pregnant with sickle cell disease? Well, it's good that if your reproductive partners, if you wish, are tested for sickle cell trait, and it's good to receive genetic counseling. And the reason that I start here is that although we're sort of focused on fertility preservation, perhaps in the context of future pregnancy, for people who are considering forming their family immediately, not preserving their fertility, but moving forward with building their families, one of the things that exists is the opportunity to test embryos for sickle cell disease. And it turns out that process looks a lot the same as the first steps of fertility preservation. So in vitro fertilization with pre-implantation genetic testing is an existing technology. It's not even new, although it's something that our community has just started talking about. It's actually been around for 20 years. This technology doesn't just exist for people living with sickle cell disease, but also for people who have a chance of having a child with sickle cell disease. This is a reproductive choice, but it's not a choice that's being shared with everyone. It also requires access to and the use of in vitro fertilization, egg harvests, and the like. There's very little data about outcomes, but I don't have any reason to think that people should be particularly glum about outcomes with this technology. The British have blessed us with a bit of data about this in 60 couples. The British system's different than the US system. And so actually this technology is available to everyone who has the chance of having a child with sickle cell disease in England. And among 60 couples who chose to use it, there were 3 women with sickle cell who were in their 30s who did use it. And all of them conceived and took home what they call it a live take-home baby rate. They all took home their babies from the hospital. So, and the live birth rate was very high in this cohort, 63%. And it would have been higher, but some of the patients dropped out because it turns out going through IVF is very, very demanding. And it's not for everybody. And so not everybody sticks with it along the way. If you're looking for a tool for thinking about what your options or your patient's options or people options are for family planning with sickle cell, and you want to understand a little more about this idea of in vitro fertilization with pre-implantation genetic testing, there's this resource. It's on the SC Red website, and it was made with input from the Hopkins community, and a picture of it is here, but it's really intended for use by our community. And so I just wanted to make sure everybody was aware of that. jump down this list for the purposes of this talk. There's a lot of things you need to do when you're planning to get pregnant. But for some people who are planning to get pregnant, I talk about fertility and infertility, because one of the important things you can ask your doctor is, if I'm at risk for infertility, how will you know when I am infertile, right? And it turns out there's a very concrete answer to that question, which is that if you have been trying for more than 6 months to get pregnant and you are having heterosexual intercourse, then you should talk to your doctor about whether you deserve a referral to reproductive endocrinology. If you're younger, they might suggest you wait until 12 months of trying, but I would say at 6 months, you want to start, if you're not pregnant after having unprotected sex for 6 months, you want to start having this conversation. And so I'm pretty nosy with my patients when they start trying to conceive, because I need to know when it's time to send them to the infertility doctors. And I'm pretty transparent about that with them, so that they can know what I'm worried about. And I don't want you to worry about it before it's time to worry about it, but I do want you to know how I'll know it's time to worry. I hope that makes sense. So why do we pay a little extra attention? Well, one reason is that something we've been learning, and it's not just us in Baltimore, but we've been learning about this from studies in England and France and Nigeria, is that egg supply in women with sickle cell disease decreases at a faster rate than people who don't have sickle cell disease. And that's what this information here is showing you. So on the y-axis is a hormone measure called anti-Mullerian hormone, or AMH. That's a measure of egg supply. And on the x-axis here is age. So you can see this is in buckets of 5-year increments of age. There's a couple more things on this picture. These dark black lines are the average AMH in people without sickle cell disease at any given age. And the gray bar is the median value of AMH in the cohort that we studied. And actually, these values were taken from the women with SS disease, 98 of them, who participated in the multi-center study of hydroxyurea. So that was the study that led to hydroxyurea's FDA approval from the early to mid 1990s. And the last thing you can see here is this 1.1 in the dotted line. 1.1 is our threshold for defining diminished ovarian reserve. And diminished ovarian reserve is particularly relevant in the context of fertility preservation, because it's a risk factor for poorer egg harvests when you're harvesting eggs. And so what you see here is that more people develop diminished ovarian reserve at a younger age with sickle. And overall, I hope you can see, if you kind of draw an imaginary line, that the decline in egg supply is faster in women with sickle cell SS disease than in those without it. And I hope that's obvious to you here. And again, this is our data that we generated using these banked samples, but you can see from the citations below, people all around the world are finding very similar things about women with sickle cell disease. And this shouldn't really surprise us, because we know sickle is a disease of accelerated aging. And so this is the ovaries getting older faster than average people. That's kind of how I choose to think about it. This population that we measured, everybody almost had taken some hydroxyurea. It's really hard to disambiguate in this study the effect of age versus the effect of hydroxyurea, if there is one. So what do we think we see? We think we see a narrower fertile window in people with sickle cell disease. Dr. Clayton Vaught and I used to work with Mindy Christensen, and she gifted me this picture. And if I get something wrong, Dr. Clayton Vaught's going to shake her head no, because that's what good collaborators do for one another. But everybody's born, we think, with the number of eggs they're going to have, the maximum number of eggs they're going to have, and it declines across time. The black line shows you the decline in people without sickle cell disease. And based on that data that I just showed you and what's supported in other data, this is sort of what I think happens. This red dotted line is what I hypothesize happens in women with sickle cell disease. Underneath this, you can see another argument for why I think the fertile window for women with sickle cell disease is compressed. And that is that we know that menstruation happens later, and we think, but we don't have great data, that menopause happens sooner. So even without any of this AMH data or anything else, you can just say that window between menstruation and menopause may be smaller, which would by logic end up with a smaller fertile window. There's lots of ways that the ovaries might be hurt in sickle cell disease, and I'm going to walk you through this a little bit. So first of all, there's the disease, and it turns out the same thing that damages the brain, the kidneys, the liver, the lungs, and all of the other organs that you've had monitored or that your children have been monitored to have injury for. Turns out the ovaries don't like any of those things either that sickle cell does. And so one obvious way that the ovaries may be damaged and that the egg supply may be reduced in people with sickle is just because of the disease itself. I'm going to talk a little bit about hydroxyurea. At this moment, there's not great data that chronic transfusions seem to affect fertility, but again, not great data is almost no data. And the novel agents, the new drugs used to treat sickle cell disease, voxelotor, crizanlizumab, and L-glutamine, we just don't have any data about. The one thing we can speak fairly unequivocally about, by which I mean we do not stutter and we are not confused, is that transplant and gene therapy are clear risks to egg supply in women with sickle cell disease. And that is because both of them require exposure to alkylating agents, which is a kind of chemotherapy. And that kind of chemotherapy is considered high risk for infertility. So bone marrow transplant and gene therapy are both high risk for infertility just based on the exposure to the strong chemotherapy required for the procedures. So infertility, we talked about this a little bit. It's a clinical diagnosis. There's a usual diagnostic criteria in people by age, but because women with sickle cell disease, their egg supply declines faster, a narrower threshold, 6 months of trying, you should at least start the process of thinking about whether you want to pursue this care. We don't really know how much time we should let young women spend trying to conceive before we send them for infertility care. Lots of people with sickle cell become pregnant. And so this is really important. What we know that lots of people with sickle cell become pregnant, even while taking hydroxyurea. What we do not know is how many people do not become pregnant. And that's the measure of infertility. And so that's the subject of ongoing study. But like I said, you should consider yourself able to become pregnant until you've had a really involved conversation with some people who know about fertility and infertility. Wanted to take a minute to address hydroxyurea because it's a real worry for all of us. And I wanted to tell you how I interpret the data so that you can think about it too. So, first of all, it's really important that we're real about hydroxyurea. Hydroxyurea is the absolutely best therapy that we have for sickle cell disease. None of the new agents beat it. It is a terrific drug and it transforms childhood. It is clearly changing what it looks like to be a child with this disease. And so the question is it affecting the ovaries? Is it a risk factor for infertility in girls who are treated? And the frank answer to that question is we don't know yet. The data, which I'm showing to you in this slide, and I'll walk you through in a minute, suggests that taking the drug is a risk factor, but it doesn't prove that it causes low ovarian reserve. So in our study where we combined a bunch of data sets, there were 84 people with hemoglobin SS or S beta null thalassemia. So this is not data about people with SC disease or S beta plus or SD or OARIB or any of those other kinds of sickle cell disease. This is 84 subjects under the age of 30. 27 of those subjects had diminished ovarian reserve. Only people who were exposed to hydroxyurea had diminished ovarian reserve. And we saw some association between MCV, which is a marker of whether you take your hydroxyurea, and diminished ovarian reserve. However, this is a small data set, and we cannot tease out whether the fact that everybody in these studies were taking hydroxyurea is really a marker that they have worse sickle cell disease. And so it's actually a function of the bad sickle cell disease and not a function of the hydroxyurea that's causing this. We see a similar thing from the menopause data of 15 subjects with S disease. And these were women in Brazil, and they had an onset of menopause if they were taking hydroxyurea that was 5 years sooner than those who were not taking hydroxyurea. I want to be really clear. The data do not make it clear whether this is because of sickle or because of hydroxyurea. And so the best we can say is that if you are someone, or your child is someone, or someone you love is someone for whom hydroxyurea is indicated, even if you're not taking hydroxyurea, you are at risk for diminished ovarian reserve. So if you're somebody who's been recommended to take hydroxyurea, even if you've never taken it, you're at risk for diminished ovarian reserve. And so I'm just putting this, I highlighted this, right? we have ways to preserve fertility, and we're going to talk more about that. We have ways to preserve fertility in that we know that in the cancer community, anybody who's exposed to a drug that may reduce their egg supply and cause infertility is offered fertility preservation. And so we can start offering better and more comprehensive fertility care to much of our patient population because of this risk of diminished ovarian reserve in the large population of people with sickle cell for whom hydroxyurea is indicated. The other thing, and I said this once, but I'm going to say it again, if you are going to pursue curative therapy intended to cure sickle cell disease, gene therapy, bone marrow transplant, a fertility consultation is absolutely indicated unless you've completed your family and you have no intention of becoming pregnant. One of the things that I'm involved in and that remain outstanding questions about this is when should we be offering families access to fertility preservation? How are we going to make sure everybody has access? How are we going to define the indications? And then I would love to be able to tell you what happens to pregnant people, to people who go through fertility preservation and IVF, but we don't actually have great data on outcomes yet. And there are people around the country who are starting to address this question together. What we do see is that with ovarian tissue cryopreservation, which is a way of harvesting a little bit of tissue, and Dr. Clayton Vaught's going to talk more about that, that we do see that ovarian tissue egg concentrations look the same in people with sickle as those without in girls. And this is just a graph. We don't have to go through it in great detail, but it's a graph that basically shows in girls with sickle cell disease, which are the blue diamonds, and girls without sickle cell disease or thalassemia, which are the gray circles, and then girls with thalassemia, which are the red triangles. This is the distribution of follicles, of eggs in the ovarian tissue, and everybody's looked about the same before transplant. And we see great variability in the number of eggs that people are able to store. The egg retrieval numbers really vary and probably is determined in part by your anti-Mullerian hormone levels and the stimulation protocol. I wanted to just go through briefly, if you're going to go through fertility preservation and go through having your eggs harvested for sickle cell disease, there's a number of landmines in the ovarian stimulation protocol for people with sickle cell. And again, this is not for you to memorize, although if you did, I think a lot of people would be very impressed with you. But this is sort of a checklist that I hope that you will review with your hematologist, with your REI doctor, and with others who may be involved in your care or your child's care if they're going through a stimulation procedure to have their eggs harvested. And I'm just going to read you this list. This is what we adopted about 4 or 5 years ago at Johns Hopkins. And it was really because we came to appreciate that our patients were having adverse events during egg harvest, and we thought we could do better to prevent them. So we really looked at the process and we said, where are the risks for our patients? So the first place is, if you're going to go through fertility preservation, I suggest that you work on making an active decision about whether you want to continue hydroxyurea while you are pursuing fertility. And by active decision, I mean, we don't know the answer to whether you should do this, continue hydroxyurea or not. And so I would really talk with your physician about what they recommend and think about what we know, which is that hydroxyurea is a great treatment for sickle cell disease, and what we don't know, which is whether eggs exposed to hydroxyurea fertilize differently than eggs that are not exposed to hydroxyurea. In general, I discontinue hydroxyurea whenever possible for my patients and start them on chronic transfusions. And that's just because I think this is a really big deal of something to go through, and I want to maximize my chances of getting it right. And I don't know what hydroxyurea does. So the conservative thing in my book is to stop it, but sometimes it's not possible. And other times my patients don't want to stop it. And so it's always a conversation. The next thing is this has to be coordinated care, because you have to know when the stimulation is going to start so that you can do things like plan a red cell exchange. We have been exchanging everybody with SS or S-beta null thalassemia to try to minimize the risk of pain events and acute chest during this procedure. Some of our patients get anticoagulation to prevent blood clots, and all of our patients should avoid steroids. So we know steroids can lead to complications in adults and children with sickle cell disease. Our beloved anesthesia colleagues, especially with OBGYN, love to use dexamethasone to keep people from throwing up as an antiemetic, but there's no reason they have to use dexamethasone to keep people from throwing up. And so we just remind our anesthesia colleagues who are caring for our patients that this is a crummy medicine for people with sickle cell disease unless there's a life-threatening indication to use the drug. So we try to eliminate exposure to dexamethasone because it's associated with pain events and can be life-threatening. After your eggs are harvested, I monitor my patients with daily weights, and that's because if you're having any complications, the most worrisome complication of egg harvest is ovarian hyperstimulation syndrome, and I monitor you to make sure you're not gaining weight, with the theory that that might be one of the first signs we would see that you're having this complication. Happily we haven't had anybody with that. Here are some questions that keep me up at night, just in case you are wondering how many unanswered questions there are. Here are the big ones among the big ones for me. So one, I talked about this a little bit. Should we use a washout period for hydroxyurea? Like I said, we do, but I don't know if we should. It certainly delays the time to egg harvest. And it may not be the right thing to do, but we do approach it that way conservatively until we have more data. Another thing we don't know for sickle cell patients is how many eggs are enough. So we know that you need some number of eggs to have a successful pregnancy, but that may be more complicated for people with sickle cell disease. What about outcomes? If you preserve your eggs, if you preserve your ovarian tissue, do you become pregnant? We don't know. It's hard to compare sickle cell disease to other standard groups because it's a different disease. You have different exposures to treatment and your outcomes are different. And so there's not like another group of people that we can say like, well, they do really badly, so it must mean that these people are going to do really badly. It's not like that. I think it's really reasonable to be optimistic. I don't think this is a place where we need to be pessimistic about outcomes. I think we should be realistic and really lean on the expertise of our REI colleagues who can interpret some of this for us. But at the same time, as a community, I think this is a very reasonable thing that we should be talking about as a way to build families and pursue life dreams for people. One really challenging problem that has nothing to do with biology is that once you freeze your ovarian tissue or your eggs or some fertilized embryos, you have to pay an annual fee. So every year it costs some money. At the moment, what we're hearing from CMS is that, at least in the context of gene therapy, there's going to be 5 years of coverage required for people who freeze their eggs or their sperm or their embryos. But 5 years won't be enough if you freeze your eggs at age 5 or 10. So we know that this cost may be a significant burden to our community, and I think we haven't quite solved the riddle of how we're going to make sure people can maintain their gametes frozen. The final thing to remember is that if you freeze eggs or sperm or embryos or ovarian tissue, all of those methods require IVF. They require in vitro fertilization for pregnancy. And even where we're seeing expanded access to fertility preservation, we are not necessarily seeing expanded access to in vitro fertilization. And as some of you may be aware, there was a very dangerous Supreme Court ruling in Alabama in the last week that has made access to in vitro fertilization even more complicated for folks who live in Alabama, and really raised a red flag for a lot of us about what the future may look like. So we know there's a lot of barriers, even as we keep pushing and we keep talking about how to do this and do what's right medically for people. There's a lot of structural barriers to getting this care. And so we have to be thinking about all these moving parts together. As we think about these moving parts together, I just wanted to make sure everybody knows. So I'm going to walk you around this from the access barriers around. So this is the statement that CMS made when they announced the gene therapy model that they're going to be advocating for. I think it's a big step that they recognize that the lack of access to fertility preservation services for our community represents a significant barrier for people pursuing gene therapy. And so we just have to keep beating the drum on this point so that we can make these access barriers lower. We can lower the gate. SC Red has partnered with Be the Match and has been, it's the only program of its kind for people with sickle cell disease in the country. If you're going through curative therapies, you may be eligible for a grant from Be the Match and SC Red, and that's very beautiful. And then we have lots of allies, but two you might be interested in learning about are the folks at the Alliance for Fertility Preservation, who are really experts in expanding access to fertility preservation. And they started in the oncology space and really thinking about the access for cancer patients, but are really interested in partnering with people in the sickle cell community and making sure that the laws that they work towards include us as well. And then finally, because we need the in vitro fertilization part to use our stored gametes, Resolve is the national infertility organization that's advocating for more access to in vitro fertilization. And so where you are, where your child is, where your loved one is in their journey of fertility, infertility, fertility preservation may vary. Some of these resources may be more or less relevant to you. And certainly all of these things present opportunities for us to advocate together. I'm just going to close optimistically by saying, I hope people will become pregnant. And the CDC recently released 3 fact sheets that are patient-facing about preconception, prenatal, and postpartum care. And so they're freely available on the worldwide internet. And I wanted to make sure that you knew that they existed, so that if they're of interest or importance to you in your life or family member's life, that you have them. They really read like a checklist of things that you can be going through with your doctor as you navigate preconception care on through to postpartum care after you deliver. So in conclusion, reproductive life planning is really important. It's okay to make a plan in pencil. Nobody's going to hold you to your plan. We just want what's best for you and what you want to do. The best thing about our job, my job, is that I get to hold people's hopes and dreams and help them reach for them. And we know that for a lot of people, having children is a critical part of having hopes and dreams for the future. Fertility counseling is really complicated in sickle cell disease. My APP teacher in high school told me, "You're never wrong." English teacher told me, "You're never wrong if you call something complex on the APP exam." And I think the same thing is true for certain things in sickle cell. This is certainly one of them. It really depends on what you've been exposed to in terms of treatment, what your family building preferences are, what your specific infertility risks are. We also know that multidisciplinary, here it says pregnancy, but it should say infertility care, with a sickle expert, with a high-risk pregnancy expert, with a reproductive endocrinologist like Dr. Clayton Vaught is really fundamental starting point for improving our outcomes. Again, I'm sorry, this says pregnancy, it should say infertility, but it's the same idea across the board. We have to be working together with our obstetric and GYN colleagues and subspecialists to improve care. And I will stop there and turn it over to Dr. Clayton Vaught, who's going to talk to you a little bit more about the nuts and bolts of ovarian tissue cryopreservation and egg harvest. And I'm really lucky. Dr. Clayton Vaught is not just my collaborator and the woman that I get to send my patients to and say, you are going to get the best fertility preservation care, but she's also my neighbor. So we're giving our talks about, 100 yards away from one another tonight. Dr. Clayton Vaught is in our department at Hopkins of reproductive endocrinology and infertility, and she also trained in medical genetics. So she knows all about your genes. Dr. Clayton Vaught, welcome, and we're glad to be here.
Thank you, Lydia, for that great introduction. Hopefully I live up to the hype. And thank you, Tiana, for hosting this very important webinar. I didn't know if you wanted to address some questions in the chat before I moved on or not.
Yeah, it's so funny you said that, because I meant to send you guys a private message. I think we're going to change up the order a little bit. Let's answer some of these questions just so we can get those taken care of. Then we'll get started, and I'm sure people will have additional questions for you. So, Dr. Pecker, when you were talking about dexamethasone, someone was curious, can you share what the brand name of that is?
I have no idea. You know?
I can't, dexamethasone is like an old drug. I bet we can Google the answer to that. Dexamethasone brand name. Decadron. It's Decadron.
Oh, Decadron.
Somewhere in my brain, I knew that. Then I had 2 children. It's Decadron, but it's actually an interesting question, because it's not just dexamethasone, right? It's the glucocorticoid steroids. So usually dexamethasone is the one that's used to keep people from throwing up. But you could have prednisone. That's another kind of steroid that we worry about if we have to give it to people with sickle cell. So really, it doesn't mean you shouldn't take it, but it means somebody should be paying attention to you. If they're giving it to you, they should know what they're doing and why they're giving it to you. If you're having a life-threatening asthma attack, you might need some steroids. But if they, but if it's for nausea, like that's not a reason that we need to give it.
Okay, good. Does iron overload affect the ovaries?
We don't know. It's a great question. It clearly affects the ovaries in thalassemia, and it's much less clear what it does in sickle cell disease. And it's something that the number of us are quite curious about.
Yeah, we need more data, you guys. So we're going to protect Dr. Pecker at all costs so she can go down this list of all these questions. Okay, so there were a couple of people who had trouble logging in, so they missed the part about what you were saying about diminished ovarian reserve in people with sickle cell disease versus anyone else. So can you just go over that one more time?
Dr. Clayton Vaught, do you want to talk about it this time or you want me to do it?
Okay, that's fine. I'll fill in as needed.
Okay, just, pull your ear if I'm missing something.
Right.
So, diminished ovarian reserve is defined by measuring anti-Mullerian hormone and sometimes also with a direct ultrasound count of the number of eggs that they can see in your ovaries. And there's a number that defines an anti-Mullerian hormone level number that defines diminished ovarian reserve. And it depends on which test you use, but it's usually 1 or 1.1, sometimes 1.2, but it's somewhere in that range. Anything below that is diminished ovarian reserve. The thing that's tricky about diminished ovarian reserve is that if you do not have infertility, it is not a great marker of whether you will spontaneously become pregnant, meaning having heterosexual intercourse. However, if you have other risk factors, and people with sickle cell disease do, it may be a little bit more of a marker of a risk for infertility. The other thing that diminished ovarian reserve does better and is best measured in people who already have a diagnosis of infertility is it predicts what your ovaries' response to stimulation is going to be. And so one of the things it does really well is it tells us that maybe, not definitely, but maybe you're going to be somebody who, when your ovaries are stimulated with hormones to make an increased number of eggs so that we can harvest them for fertility preservation or for IVF, that maybe if you have diminished ovarian reserve and we stimulate you, your ovaries are going to have a less strong response. They're going to release fewer eggs in response to that stimulation. And so that's why we pay attention to diminished ovarian reserve. And as we move towards a time when more people are thinking about curative therapies, the fact that a larger percentage of people with sickle cell disease have diminished ovarian reserve becomes more important, because ideally we'd be freezing your eggs before you ever develop diminished ovarian reserve. It would be really nice to be able to predict who's going to develop diminished ovarian reserve really early, so that we would know we need to intervene before this becomes severe. I hope that helps a little bit.
It was great to me. Any plans to compare ovarian reserve in people on hydroxyurea and people off hydroxyurea so we can see what hydroxyurea is actually doing?
Yeah, thank you for that excellent question. Studies are ongoing. One of the things that's really difficult, right, is that a lot of people have taken hydroxyurea some and stopped taking hydroxyurea some and started taking hydroxyurea some. And so I think as a purist and a believer in the best science, I think the population of young people who are going to help us answer this question best are the children who are being started on hydroxyurea at 9 months of age. And we know why to start children. Just to be clear, like, it's really important we don't stutter about this. Children need treatment with hydroxyurea because it transforms childhood, totally transforms childhood for children, affected children. The question is, when they grow up, what does their egg supply look like? And I think that will be a very important question to the community. The youngest children treated with hydroxyurea with the baby hug study and the early studies of hydrea in children, they're just turning into teenagers. So I do hope that in the next 10 to 12 years, young people will light our way in terms of answering this riddle.
Okay, the hydroxyurea questions are blowing up. Someone said that in animal models, it was shown that hydroxyurea affected ovarian weight and size.
Yeah, it's really hard to know what to make of that animal data. It's in mice who did not have sickle cell disease. And so it's really hard to know that data. The thing that I pay attention to in that data, they also showed that embryo development was affected in hydroxyurea-treated mice. And it's actually that data point that is the reason that I stop hydroxyurea in my patients who are going to fertility preservation. And I also stop hydroxyurea in people who are trying to become pregnant. Not everybody does that, but that's all the data that I have at the moment. We certainly have lots of anecdotal data that people taking hydroxyurea have become pregnant, have gone through egg harvest, but we have less data on who doesn't become pregnant and whether those embryos fertilize differently.
Okay, and then there's just one more question before we get to Dr. Clayton Vaught. And this is a question that came to my cell phone, is not in the chat. So there are some gentlemen joining us, and they are concerned about their sperm count on hydroxyurea and wanting to know if when they stop hydroxyurea, will their sperm make some type of recovery?
Back. Yeah, so great question. Another question we don't have a perfect answer to, so I'll just speak from my clinical experience. So first of all, remember, sickle cell disease damages the testicles and it impairs sperm. So many, many men with sickle cell disease have abnormal sperm counts and abnormal sperm behavior. So like the shape of the sperm, the way it moves, all of those things can be affected by sickle cell even without hydroxyurea. We definitely see that hydroxyurea knocks down sperm counts in adult men. In my clinical experience, stopping hydroxyurea leads the sperm to come back. So I've had a number of patients stop hydroxyurea to bank sperm, and all of them have had sperm come back and been able to successfully bank. So sometimes it can take some months, and whenever possible, I put those patients on red cell transfusions because that's the best protection from sickle cell disease I can offer you when you're not taking hydroxyurea.
Great. Okay, Dr. Clayton Vaught, take it away.
Oh, that was a workout. Thanks, guys.
It's getting robust.
In there for me, so hopefully I'm not gonna have to say much. Let me see if I can get this presentation thing. Today I've been technically challenged. So I'm trying to figure out how I can share my screen and this presentation.
Do you see where it says present on your screen right now?
Yes.
Okay, if you click on that, it should allow you to add your slides.
Oh, add my slides. Okay.
Mm-hmm.
Hold on. Let me make sure they're saved.
Okay.
Good, right? All right. Sorry about that.
Well, Dr. Pecker, I'm curious to know, being a hematologist, there's not many hematologists who have like taken research interest in like fertility and ovarian reserve. So what inspired you to do that?
Tiana. When about 5 or 7 years ago, I was thinking about unaddressed research questions and my own interests in sickle cell and reproductive health. And one of the things that stood out to me was that we are now starting our babies on hydroxyurea. And we know that for a fraction of families, the unanswered questions about infertility risks are a real barrier to accepting the medicine. And it seemed to me this was a question we could answer. But nobody had looked. And so I sort of started there. I used to be a pediatric hematologist, and about 5 years ago, I started working in the adult space, which is where I am now. Turns out it's much easier to answer this question in adults than it is in children. But it seemed to me like we had an opportunity to answer a question that our patients and our community had been saying was important for a long time. And so I had an opportunity to write a grant, and I got the funding. And so and I work at a place where we do a lot of research, and we're exceptionally lucky that we care for patients who trust us and who are willing to participate in our research and are willing to partner with us, because we can't do it without them. And we tell them all the time, we can't do sickle cell research without sickle cell patients. without sickle cell advocates. And I'm also really lucky because my office is not that far from Dr. Clayton Vaught's office. And so when I needed someone who was going to be able to help me with this research, because not only did I need patients who were willing to show up on day 3 to 5 of their menstrual cycle to get their egg supply measured with a transvaginal ultrasound. I mean, my patients are real heroes for going through this research study. But I also needed a heroic reproductive endocrinologist who actually knew how to do the ultrasound, right? That's not something that hematologists have training in. And so I was really lucky that I worked at a place where I have these amazing colleagues who say things to me like, yeah, I can see why that's an important problem and I'd love to help you. So I think there's not really a better way to introduce Dr. Clayton Vaught than that, actually. So
thank you. Thank you. I figured out is it showing? Are my slides showing? Okay, great, because it failed upload twice. That's why I was just like, go, keep going. But yeah. All right, great. So again, my name is Kamaria Clayton Vaught. I'm one of the assistant professors at Johns Hopkins in the Division of Reproductive Endocrinology. So today I wanted to just talk about in general, it's cancer, but it's not cancer. Forgot to change this one. So fertility preservation in patients with sickle cell disease. So I wanted to first highlight some patients' concerns, right? So one of those include the fear of perceived risk of treatment. So this is the whole process. Like it's like the great unknown of IVF. You hear a lot about it. A lot of people who have experienced it. And it can seem very daunting, especially when you have a very challenging medical condition that you are working around. There's emotional distress to this. There's issues with relationship or parental status, meaning that, I'm unpartnered at this time. Can I go through IVF, or, do I actually want to be a parent in the future? But I don't know that question, answer that question right now, but the time or the window that I have to preserve my fertility is limited. So you're kind of having to make decisions a lot quicker than what you may want to. And then obviously there's like financial concerns, right? About the cost and access to this type of treatment. So this is a really busy slide, and this is again taken from the cancer literature that I think can be also extrapolated to our sickle cell disease population. And it just is really just a whole decision tree of what you as a patient or our patients with sickle cell disease may be going through in their thought process, right? Can you see my arrow moving at all? I don't know if that's possibility, probably not. Okay, well, all right. So and the left-hand side of the screen, you see before treatment. So, discussing with your family or your partner, or not discussing with your family or partner, you receive like maybe these personalized options from your REI specialist. During the treatment, again, whether to discuss this with your family members or after treatment, what happened afterwards? Do we need more treatment? Again, discussing this with your family or not. And then when you decide to pursue treatment, okay, well, there's a treatment itself. Will this delay my own care? Like if I need a bone marrow transplant, or if you're going to go gene therapy, how much is this going to delay my own treatments? Financial burdens, can I afford it? Storage, like Dr. Pecker had alluded to earlier, where, I have eggs now, or I've created embryos, where will this go? How long will I store it? When can I come back to use these, right? And then your partner, maybe you're doing this on your own. Maybe you do have a partner. Does anyone have rights to my eggs or my embryos in the future? Am I even with the current partner that I think I want to have children with? And then what to do with these, right? So we talk about this and we try to frame it in the sense that we are preserving your fertility. And I like to tell my patients, think of it like having an insurance policy on your future fertility, right? So this is just something that you may need in the future. Do you need to come back and use these eggs? Do you need to come back and use these embryos? Maybe not. You may be able to get pregnant on your own. And if that's the case, what do you do with excess embryos or eggs? Donate to research, destroy them. What are your religious and your social and your familial influences that will help you make those decisions? And then again, like I talked about earlier, parenthood, like do I even want to be a parent? So there's a lot of decision fatigue already on the outset for our patients without even getting into the nitty-gritty of IVF. So first, I'm going to talk about just some fertility preservation options for individuals with ovaries. So the four main ones we're going to talk about today include embryo cryopreservation or freezing, oocyte or egg cryopreservation and freezing, ovarian tissue cryopreservation, and then third-party reproduction. So first, let's talk about embryo and oocyte cryopreservation. So this is what we traditionally think of as IVF or in vitro fertilization. It's a process of what we call controlled ovarian stimulation, and this is with injectable hormonal medications. These are preparations of follicle stimulating hormone, FSH, and LH or luteinizing hormone. So these are hormones that your brain is already producing, and we are giving you these to help maximize your follicle egg development. So normally every cycle you recruit one egg and that egg is ovulated. Our goal for IVF or egg freezing is to get as many of those as possible. So we're really giving you a lot of higher dosing of this medication in order to stimulate the ovaries to form all those follicles and eggs. Those eggs are then surgically retrieved to either freeze for later or assimilate with sperm to create embryos. The whole timeline with the process of IVF takes about 2 weeks. So that's beginning at the start of medication to when the eggs are retrieved. Now, the medications that I talked about are injectable medications. So these are medications that you will be giving yourself in right below the skin. We call it subcutaneous injections, usually in your lower abdomen. And these options of egg freezing and embryo freezing is the fertility preservation approach with the highest chance for future pregnancy. Future live birth is really dependent on one, the number of eggs that we're able to get and or the number of embryos created. And most importantly, the age of the woman at the time that this is happening. And I'm going to talk about that a little bit later. So for embryo cryopreservation, there's a few key things that you need to have. So available partner sperm or donor sperm. Once we create embryos, we can do additional downstream testing like pre-implantation genetic testing to identify embryos that may be at risk for sickle cell disease or other what we call monogenic or gene disorders. And so this is what we call PGTM or pre-implantation genetic testing for monogenic disorders. We could also do what we call PGTA, and I have a slide on that later, which is where we test the embryos to see if they have the normal number of chromosomes. And like I said, I'll talk about that a little bit later. And embryo cryopreservation usually gives you the highest and the best pregnancy rates. Then we have egg freezing, which does not require a sperm at all from a partner or a donor. We can't do any genetic testing on eggs. You usually have greater control of what to do with your eggs since you did not form an embryo with someone that you're creating and sharing with. So you ultimately have the final say of what to do with those eggs. There's a lower attrition rate. So what I mean is that while we have eggs that are freezing, eventually if you decide to come back and use those eggs, we would need to create embryos from those. So say you may start off with 10 eggs. Again, based on the age of the woman, that may only result in maybe 1 or 2 embryos when it's all said and done. So doing embryo freezing, you kind of have a more upfront number or idea of what you're working with versus egg freezing. The technology between the two are pretty similar. Egg freezing used to be a different method that we use. Now we use what we call vitrification. And it's really, really good in centers that do a lot of egg freezing and thawing cycles that we're getting very similar survival rates as we are to embryos. And again, we're having lower pregnancy rates with just egg freezing. And that's because we don't know how many embryos we can get from a batch of eggs. Lydia already, or Dr. Pecker already talked about this. Her graph was like more up to date. Mine is from 1998, but it's only but goodie, like I like to say. So as you know, women or a person with ovaries, you're born with all the eggs you're ever going to have. Okay. And so that's about 1 million or so at birth. And by the time you reach menopause, it's about less than 1,000. And so depending on where you're at in your own individual egg supply or varying reserve, that will dictate how well or how you would respond to IVF. Your age has, I will say this, and you'll hear me say it again and again, like 80% of it is driven by age, okay? And what I mean by that is that the eggs that you have had since before birth, over time, they're also becoming less, but they also are losing quality. So, and when I talk about quality of the eggs, I'm talking about the genetics of the eggs. So they tend to be abnormal the older you get. And so not only are you dealing with the lower egg supply, you're also dealing with a lower egg quality as you age. And so the ones with the abnormal genetics are less likely to be fertilized and less likely to end in a viable pregnancy, more likely to end either in a failed, pregnancy or an early miscarriage. And so to give you an idea of like the rough numbers, by the time you're 37 or 38, about 50% of your eggs are abnormal. By the time you're 40, looking at 60 to 70%. By the time you're 43, 44, 90% of your eggs are abnormal. So we are dealing with a very finite or limited window when we are talking about egg freezing in IVF. Now, as Dr. Pecker had mentioned, we think persons with sickle cell disease already are at a lower baseline than patients who do not have sickle cell disease. We do not think, or we don't know, if the quality of the egg is affected with sickle cell disease. Right now, all we can say for sure is that the quantity may be affected. So again, this is just another graph kind of saying that, meaning, as you get older, the chances of conceiving per month decreases. So if you look at on the x-axis is the age of the women in years, and on the y-axis is their chances of conceiving per month. So this is in a population of fertile women. So these people do not have any issues with conceiving. And as human beings, we're super inefficient at getting pregnant. Okay, so even at our most fertile, we're only about 25% chance of conceiving per month. And so you can see as we get older, the more lower likelihood of pregnancy occurs. So let's also talk about the timeline for IVF, because again, this is probably one of the most common questions that I do get. So if we look at cycle day 1, okay, so this is the first day of a menstrual period if you're still having menstrual cycles. And this is when you would call us, let us know, hey, I'm on my period, and then we would have you come in for ultrasound to assess what your ovaries look like. So on the far left, here's a picture of an ovary at the very beginning of a menstrual cycle. It kind of looks like a chocolate chip cookie, but you see little tiny small circles. Those are follicles with potential eggs in them. Our goal is to get the ovaries to grow and respond using the IVF medications to looking like this on the far right, big old grape cluster. So typically that requires several visits to the fertility clinic. So with the initial start of the medications, you start them, they take them for about 4 days, you come back for another ultrasound, we check more blood work, we make sure that everything is appropriate, we had to come back a couple days later, and so forth and so on. So like I said, the average stimulation is about 10 to 12 days on these medications, and then once we decide that these follicles or these eggs have reached a big enough size, we go ahead and trigger ovulation. Now, Dr. Pecker already talked about the protocol that we have in place for persons with sickle cell disease who are undergoing this type of controlled ovarian stimulation. So there are certain, protocols and benchmarks that we want to have established prior to the start of this type of a cycle and during the cycle and through completion of the egg retrieval process. And so after we trigger, we do the egg retrieval. This is done usually in an outpatient setting under a monitored anesthesia, so through IV sedation. And so you're put to sleep, you're comfortable, you do not feel this procedure, okay? Your pain is controlled while you're sleeping. Now, dealing with pain control issues afterward is something that we also have to think about and prepare for in this patient population. But for the most part, I would say our patients, my experience, and Dr. Pecker, I don't know, you can disagree, but for the most part, our patients are well tolerant of this procedure. We have like an N of one, maybe did not.
Well, especially after we changed our protocol, which kind of predates you, Dr. Clayton Vaught's only seen the very best outcomes. But right, we did learn from our experiences. I'll be quiet now.
And so here you can see this is like the view, the gray, black, and white pictures, what I see during the egg retrieval. So you can see there is a follicle, there is a needle in that follicle, and we are aspirating out the eggs and collecting them in the tubes. Once we collect them in the tubes, our embryologist will then take a look in the microscope and let us know how many eggs that we have, how many of those are mature. Then depending on if you want to move on with IVF, meaning fertilization, then we may introduce sperm. If not, then at that point, all the eggs would be frozen that are called mature eggs. And those are the eggs that can be potentially fertilized with sperm in the future. There are two different methods of fertilization, or what we call insemination. This includes conventional IVF or ICSI, or intracytoplasmic sperm injection. So this is with conventional IVF, there is a bunch of eggs in a petri dish, and then put them with a bunch of sperm and we let them fertilize. Versus with ICSI, we take a single sperm and inject it to a single egg. There are different indications for ICSI versus conventional IVF. Maybe there's not a lot of sperm available, so we want to use it, or there's a male factor in addition to the reasons why you are undergoing fertility perturbation. So those are the different types of fertilization. Once fertilization occurs, we grow out those embryos to around 5 to 7 days, up to 7 days in our lab. So you can see in each day, it's a progression of the embryo of the cells dividing and multiplying until by day 5 and day 6, we have what we call as a blastocyst stage embryo, where it has both hundreds and hundreds of cells. And so this is the stage embryo that we usually would freeze. So for patients to come back and use later. And this is also the stage of embryo that we do any type of genetic testing on. A lot of times embryos may not make it to the blastocyst stage. They may arrest their development. They may stop at day 3 or day 4. And in those embryos, we usually typically recommend discarding because they would not be suitable for transfer and would not result in a viable pregnancy. If you decide to come back and use your embryos, we would do a uterine transfer of them. And so this is things that we do to especially prepare the lining of the uterus in order to be receptive to embryo. But that can be kind of like on the back end of things. But that is required whenever you want to come back and use your embryos. I'm gonna talk about a little bit about PGT, and I'm gonna try to speed through this because I realize that I'm talking a lot and I don't have a lot of time. So we have what we call PGT-M and PGT-A, which I kind of introduced earlier. So really, I want you guys to focus on the far right of the screen here. This is, again, the blastocyst embryo, and this is the embryo that we take the biopsy from. So we take about 5 to 10 cells from the outer ring of what you see here, which is the trophectoderm. So those are cells that eventually become the placenta. That inner cell mass, right at 12 o'clock, those are cells that usually become the baby, and we do not biopsy from them. Okay. So once we send that tissue off to genetic testing and processing, usually depending on the type of genetic testing that we're doing, it takes about 7 to 14 days to get those results back. So nowadays, PGT can be performed for any genetic disorder for the most part. Some labs kind of, I think, overpromise, maybe underdeliver on that. But when we know there is a very specific gene or familial mutation, we can test for that. So if we're concerned about sickle cell disease in offspring, we can test for that, or any other inherited condition that may be running in the family. There are other types of PGT. One is called PGT-SR for structural rearrangement. So this is in couples who may have different arrangements in their chromosomes. And then there's PGT-A for aneuploidy. So this is one of the most common indications for PGT, and this is determining if an embryo has a correct number of chromosomes or not. And this, like I mentioned before earlier, is when you have an age predominance. So as you get older, more embryos are going to be abnormal, or what we call aneuploidy. This picture here, I like to think about, so what are we testing with PGT-A? We're testing to see the correct number of chromosomes. So think of your chromosomes as your encyclopedia, okay? They are your instructions for your body to grow and develop. We have 22 autosomes and, sex chromosomes, X and a Y, 2 X's if you're a female and X and Y biological male. And so each of those chromosomes are books on the shelf. So if you're missing a book, that doesn't do well, okay? It usually ends in a non-viable pregnancy or early miscarriage. If you get an extra copy of a book, the same thing happens. So you may have heard of something like trisomy 21 or Down syndrome, which is when you have 3 copies of chromosome 21. Those are the type of conditions that we can test for and identify with PGT-A. When you're looking for a PGT-M, it's more detailed. So we are actually opening that book up. We're going to the sickle cell chapter and we're sequencing that whole gene. Or we're trying to find that gene, okay? And we're saying, yep, this is the affected gene or chapter, right? And we can say this whole chapter is missing, or there's a letter error spelling, which is what happens in sickle cell disease, that is causing this. And so we can identify these embryos and then only elect to transfer embryos that may not have that condition. So some things to consider: IVF is a surgical procedure with related risks. So we have infection, bleeding, there's potential harm to surrounding organs. There's risks are very minimal, more so in patients with sickle cell disease, but something to take note of, okay? There's always a chance that IVF no eggs are retrieved. So especially in our patients with a lower egg supply or diminished ovarian reserve, like Dr. Pecker mentioned, when you have that lower AMH level, that is more likely to represent either a not successful IVF cycle, so where we have very few eggs retrieved, we're talking about 3 or less, or we need very high doses of medications, or we need multiple cycles of IVF to get our desired result. So that is something, especially that can be very challenging when we're already faced with a potential lower egg supply. And then if you elect to do genetic testing, after testing, there may not be any suitable embryos to transfer. Okay, either all embryos are affected with that gene condition, or they may have an abnormal to number. IVF success, or the chance of success. So we think of IVF success as pregnancy with a live birth. And that success is highly dependent on the age of the female at the time the eggs were frozen or embryos created, as I mentioned before. And then women who are less than 35 at the time of IVF have a significantly higher chance of live birth than women who are over 35. And again, this is mainly due to the abnormal chromosomes in the embryos that increases maternal age. So I will talk about a couple other forms of fertility preservation. One is called ovarian tissue cryopreservation. And just briefly, I'm not going to get into the nitty-gritty of it, just in the interest of time, but it's essentially a therapy that we offer our pre-pubertal girls. So our girls who haven't gone through puberty yet, who don't have eggs that we can readily stimulate and retrieve. So these patients, we would take a piece of their ovarian tissue and we would then freeze it. So in the hopes that when they do become the age. So these are especially, I'm thinking, our patients who are going to be undergoing gene therapy at a very early age, or that becomes more readily available, they can have that ovarian tissue cryopreserved, so that when they are ready to start their family, you could potentially come back and activate this ovarian tissue. It hasn't been a lot. This is considered experimental. And so hopefully, depending on, I guess, legislation in the future, this will be something that is covered for patients who are undergoing fertility preservation. The last thing I'll talk about is third-party reproduction. So this is where we use donor eggs, donor sperm, or donor embryo. So sometimes, and unfortunately, a lot of the times, I'm seeing patient or counseling, it may be too late to use their own eggs or their own gametes. But that does not mean that they cannot have a family and that they don't have family building options. So we do have technology that we can use donor eggs for, or sperm, so that that patient can still potentially carry a pregnancy, and then have a child, even though it may not be biologically related to them. And then there are some patients who just have too much of a medical complication or risk to even carry a pregnancy. And so for those patients, we may be able to, in the past, or got embryos or eggs, or have these available, and then we can use gestational carrier in the future for them. Then obviously, the last option, not as a last option, but the last thing I'm talking about is adoption as well. So there are multiple ways to potentially build family in that sense. So I'll very briefly talk about individual testes. I didn't know if I was supposed to or not, but we do have men here. Men are pretty straightforward, or persons with testes. So a few ways that we can do, Dr. Pecker already talked about, is either ejaculated sperm. So you have ejaculated sperm and then you freeze it. You can do cryopreservation of surgery extracted sperm. So for any instance where a man may not be able to ejaculate, we can actually go and surgically retrieve sperm. And then there's testicular cryopreservation, which is similar to ovarian tissue cryopreservation, but for in men. And this is something that we do not routinely offer, and it's very experimental. So I'll just talk about, Dr. Pecker pretty much already said what I had to say about this. With person with sickle cell disease, they already have maybe a low sperm count. Their sperm is affected by hydroxyurea. So we want to collect as much sperm as we can. So that's exactly what we do. We collect it via ejaculation. We want a good number of samples so that we can use it in the future. And that sperm could be cryopreserved. Any sperm, embryo, egg can be cryopreserved indefinitely. Then I will skip the different types of cervical extraction methods, but that is a possibility as well. And then we talk about testicular tissue cryopreservation as pretty much the only option available for prenatal boys at this point. Other considerations for individuals with testes. So there are some people who think maybe hormonal therapy in men should be for fertility preservation. That's not recommended. It's not successful. Sperm counts and quality sperm may be reduced in patients undergoing toxic treatment. So this is what Dr. Pecker alluded to, with the shape of the sperm being different, the motility or its ability to move also being affected. And then these are for patients who may be undergoing like bone marrow transplants and whole body irradiation with chemotherapy. There is a potential higher risk of genetic damage of sperm. So the recommendation is actually not to try to cryopreserve any sperm or to get pregnant for at least 2 years after any chemotherapy in these men. So that's something to think about. And then also, again, what Dr. Pecker alluded to, financial costs is a huge barrier to our patients with fertility preservation. Here's a slide. I'm going to put it up here, just kind of a rough estimation of these things cost, and it's significant. So for IVF, you're talking about $10,000 to $15,000 per cycle. That's including medications. You have storage fees that Dr. Pecker also talked about. sperm banking, and is a lot cheaper than going through IVF. But unfortunately, at this point, we don't have a lot of options for our patients as far as their ability to access to care because of the financial burdens. But hopefully, like in the state of Maryland, there's some legislation that is coming around that may offer these services to our patients. And then briefly talking about just insurance coverage. So insurance coverage for infertility treatment, not just fertility preservation, is not guaranteed, period. Okay, there are no federal laws that require coverage for infertility treatments, and only about 1 in 5 employers will provide fertility treatment benefits to their employees. So you can imagine, as a subset of that, fertility preservation patients, it's even more dire. This is a map of the United States that I got from Resolve, which Dr. Pecker also mentioned, of an advocacy organization for persons with infertility or undergoing fertility treatments. And you can see all the grades, all the states that don't offer fertility coverage, period. Okay. And then the different colors, it kind of stratifies of what they do offer. If you pay attention to the bright yellow and orange, those are states that offer IVF and fertility preservation coverage. I put a caveat to that because fertility preservation for these states means patients with cancer, okay? And not patients who have sickle cell disease who may be undergoing and have risk to their threat to their fertility. Maryland, Dr. Pecker and Tiana are trying to change that. So we're really, really hopeful that we can get this for our persons with sickle cell disease, but it's very minimal coverage. Okay. I want to just wrap up by saying thank you. I am here for any questions that anybody may have. I know what I talked about is a lot and can be very overwhelming. So I want to thank you for your time and your attention. And thank you again, Kiana, for putting on this.
Thank you, Dr. Clayton Vaught. That was an incredibly informative presentation. I learned a lot myself. And I actually did get some questions. They were sent to my phone and my phone just died. So for all of you that texted me, I'm going to try to do this from memory. Thank you for also touching on the different family planning options and for addressing the guys that came up. There was a question about, I know you said that it's almost like a roll of the dice. Like you don't know how many eggs you will get per cycle. So you said that you could go through this and not even get any. And someone wanted to know if that happened, like say you didn't have a good cycle, you didn't get many eggs. Does that affect the likelihood? Does that like say anything about future cycles?
The future IVF cycles or future to get pregnant?
Future IVF cycles.
Yes. So Dr. Pecker mentioned earlier about AMH. So traditionally AMH has been studied exclusively for patients undergoing IVF. And that's where we have the most literature or the most data from. And that cutoff point, as she mentioned, of 1. So patients with AMH level less than 1 are more likely to have not successful IVF. But we don't really know how someone responds to an IVF cycle until they go through an IVF cycle. The best predictor of your response to IVF cycle is how you did in a prior IVF cycle. So if you did not do well in a prior IVF cycle, meaning, maybe about 1 or 2 eggs that were developing, maybe 3, then it's very likely that in subsequent cycles, that is also going to be the case. Now, again, that doesn't mean that we can't go forward and retrieve those eggs. We have a patient that had something very similar happen with her, and Dr. Pecker's patient as well, but she went through multiple cycles. But when you have a multidisciplinary team that is well prepared to handle that, then that is something that can be done in a safe manner as well. So, the good thing again that she had on her side was her age. So even though we may have had fewer eggs, we had the quality of the eggs we suspect are still very high. And so those will have a higher chance of resulting in a potential embryo or pregnancy.
Okay, great. So just for clarity, because this is something else that I'm also curious about, and it came to my phone. There is no specific lab that you can take that will show you're infertile.
There are so it's not. Let me preface it with this way. So there are many different causes of infertility. So when we do an evaluation of a patient, we do a whole workup, right? So now you're really exclusively just focusing on eggs, the amount of eggs you have, and the quality of eggs you have. But there are other causes. Maybe someone's tubes are blocked. Both tubes are blocked. That person is infertile, right? Maybe they have terrible fibroids, or maybe they have polycystic ovarian syndrome or endometriosis. So there are other causes of infertility. But I don't know if the person want to know, is there maybe a single lab that predicts what your egg supply is? The answer is no. So I use AMH as a tool, and I like to say it's a piece of the puzzle, right? It doesn't tell me everything. What I'm looking at is your AMH. What I'm also looking at is how many eggs do I see when I look at your ovary on ultrasound, right? So if that's low or lower, and your AMH is also low or lower, they agree. And so that kind of gives me a more idea that yes, this egg supply is. We also look at hormone. So certain hormone levels like FSH, or maybe they're elevated in the beginning of the cycle when I would expect them to be low, because your brain is saying, hey, ovaries, make more eggs, but the ovaries are like, hey, we don't have any. So your brain is going into overdrive trying to get the ovaries to respond. So those are all parameters that we want to at when we're evaluating patients, seeing one who are very reserved. I don't know if everyone did, but there's no single test that says you're fertile. Okay. No, well, I will say this: there is. If I did an HSG or look at your fallopian tube and they're blocked, but not in the sense or sickle cell patients. No.
Okay. So say someone just got off of this webinar and now all of a sudden they're curious about their own fertility status. What is the first step? Like, what should they do?
Come see me or a reproductive specialist, honestly. It does no harm. It will be very informative for you. If that's something that you can't get in to see, whether that's insurance reasons, or maybe there's not a specialist close to you, even going to see your OBGYN and voicing your concerns, because they can be your advocate and help you get to that person that you need to for a full evaluation.
Okay, and what would that evaluation entail? Would it just be labs?
Yeah, so it's a full gamut. So we do a history, we do labs, to look at, egg supply, ovarian reserve, and then we kind of go from there. I do a follow-up visit usually afterwards, so we can talk about what we see. Again, sickle cell disease is not a monolith. There's variations, and I've definitely had patients who have completely normal egg supply and ovarian reserve. Based off of that, we talk about, all right, so everything looks good right now. Is this an optimal time to pursue something like this? Because we don't know what the exact risk of is to your fertility in the future. But right now we know we can probably get really good response.
Mm-hmm.
Or right now you have some time, whether that's, you're not ready to go through this or things like that, and you kind of have an idea. Versus maybe it's the lower end. So I'm talking about, okay, well, maybe we're really thinking about doing this now, or maybe you're older, so our time is not as much that we have to work with. So it really is, individual evaluation, but for the most part, it starts off with just a history and some basic blood work.
Great. Okay. There's some concern that there are some of us who don't have access to these multidisciplinary teams. So one, how important is it to find a fertility specialist who's familiar with sickle cell? And for someone who does not have access to someone Which should they be prepared? Like, how should they educate that endocrinologist?
Dr. Pecker, you can talk to that, but I would say it's very, very, very important that your fertility specialist be aware of how to safely proceed with fertility preservation cycle in a patient with sickle cell disease. And I will tell you, it's limited.
Yeah.
And that doesn't mean that Dr. Pecker and myself are not available for that person. We have a network of infertility specialists, but we're a small group and we all know each other. So in the event that you may not be Maryland or close to Dr. Pecker or myself, it's a small group of people and we talk. And so just say, hey, I know Dr. Clayton Vaught and Dr. Pecker, they talk about the protocol with this, I'm reaching out. And we would be super elated. But Dr. Pecker, you can also put in your thoughts.
Yeah. So first of all, we know this is a really serious problem. So I just want to affirm that this is a real problem. I think there's a couple of things that you might use as a guidepost in this. First of all, if you need to see a sickle cell specialist, your sickle cell specialist can help any reproductive endocrinologist who sees you. That's not a substitute for reproductive endocrinology expertise, but as with all things sickle, it's really helpful to have a specialist, a sickle cell specialist. Again, not everybody is privileged to have a hematologist in that role. If it's a primary care doctor, whomever it is who cares for you. The second thing is based on where you live, somewhere in your state, or perhaps across a border, but you may not have care access depending on your insurance across a border, and I appreciate that. But there should be, in most states, an academic reproductive endocrinology practice. Again, not in every state maybe, but in most states. And when I say academic, I mean it's associated with a university of some kind. So it's either a state university or a private university, like Johns Hopkins is a private university. If you live in Chicago, for example, the folks at Northwestern are very interested in reproductive endocrinology for people with sickle cell disease. If you live here in Baltimore, right, there's us. We are working on building teams where this exists, but I would say it's much more normal to not have a team of people who have expertise in this at this point than to have people who do. At the same time, we now know there are not adequate, but there are some resources because we've written about it. We've posted it on Twitter. We've talked about it. We've recorded ourselves talking about it. We've posted the recordings in various places across the internet. So we know there are ways that we can be sharing resources with one another. And like Dr. Clayton Vaught said, she and I and others of us who are building this big network of people, we're glad to be resources for the people who are caring for you. But I think starting with your hematologist and working your way out from there may be a very sensible way to go. And again, if it was me, if it was my child, I'd be looking at the academic practice, most likely in my area, not a private practice, but an academic university setting for care, because those people tend to be interested in reviewing the literature, interested in diverse challenges associated with reproductive endocrinology and infertility. Some of the private practices, this is not to throw shade on private practices, but there's heavy emphasis on successful pregnancies in the private setting. And a lot of clinics will publish their data on how successful they've been at getting people pregnant. And it turns out if that's sort of they are able to therefore select who they care for. So that they take care of people who have more favorable pregnancy outcomes. Most of the academic university settings, people are not as focused on a sort of capitalistic model where you have to prove that you're winning. It's more focused on taking challenging cases on and getting things right for people. So that's why I'm putting this emphasis on academic practice for this particular niche issue. And certainly with gene therapy, again, this is increasingly on people's radar, at least in the sickle cell community, because people are less naive to the reality, that gene therapy is associated with a need for fertility preservation. I hope that helps.
That was very helpful. Dr. Clayton Vaught, I'm going to put you on the spot a little bit, just for like my own curiosity, because I attended my first ASRM, which is American Society for Reproductive Medicine, last year. And I was not aware that there's only like 50 Black REIs. And I was just wondering, why do you think that is? And as a follow up, what got you down this path?
Yeah, no, so we're very underrepresented in reproductive medicine as Black physicians in general. I mean, I think it's the reason why is why there's a lot of representation of medicine in general. But on top of that, REI itself is a very competitive field, especially when you go into, and it's very mainly driven by very limited spots. And so, like when I was in fellowship, there was probably, depending on the year, 35 programs in the whole country. So, and they may be taking one person a year to train. So it's, you imagine like compared to thousands and thousands of GYN graduates, the number of spots for it. So unfortunately, that plays a huge role in it, although we are trying to increase the pipeline and diversify that pipeline for our incoming fellows. So I am the vice chair elect at the Health Disparities Group for ASRM. So it's on our priority list to not only gather more potential trainees, but also to exposure and the of REI to going into medicine, because people are like, what is that? I never heard of that before. So trying to get even at the undergraduate level to increase their exposure. So it's a very passionate project of ours. But my interest for, I guess, going into the field of REI is personal. I had a family member affected with infertility, and I saw the struggles that they had to go through. I knew it sounds very cliche, but it's true. Like I felt like parents when I was 5 that I wanted to deliver babies for a living. They didn't believe me, and then I kind of sort of did that for a few years, and I said, I'm not going to deliver any more babies. But I did go. Women's health has always been very dear to me. And so I realized that I am very privileged to be a part of a woman's life or a couple's life when they are experiencing a very difficult thing to go through that's very personal to them, and emotionally, financially, and mentally exhausting. So I am super lucky every day that I have my patient, that I really get to do what I love. And on top of that, I get to do research that I love to help, these patients in the future for a very young field that REI is. If you think about it, the first, IVF baby born in the 80s, it's very, very, very new. So I'm hoping that my contributions will help advance and propel the field. But that's kind of like why I got into it. I'm kind of nerdy. Dr. Pecker was the whole team. Like I have a whole lab. I'm in the lab, I'm in the research, I'm doing like experiments. So it's very, very fulfilling to me.
Awesome. Well, thank you both so much for joining us. This was an incredibly informative discussion. It was really robust. And thank you, everyone, for tuning in, for making it a robust conversation with your questions, kept us on our toes. Yes, DeAndrea, I know that it is like really emotional and that the barriers are numerous, particularly the financial ones. And you know that I am working overtime to try to eliminate some of these barriers. And so I have a lot of work to do, but Dr. Clayton Vaught and Dr. Pecker have been really instrumental in this work as well. So I'm hopeful that we're going to continue to move the needle. And so thank you for joining us. Our next webinar is March 14th. It's kind of like a follow-up to this webinar. We're having an ethicist join us who's going to kind of talk about the ethical implications of not having access to these services. And then we're going to have a panel discussion. And then the webinar after that is going to be with Dr. John Tisdale as a follow-up to the 60 Minutes special that came out, which will also have a panel discussion. And then the one after that is going to be on pregnancy with Dr. Kim Smith-Whitley. So we will be sending you guys all of that information so that you can join us for the rest of the year. So everybody have a good night, and we'll see you next time.
Thank you.
Bye.